So briefly, the DAPT study, which was published in the New England Journal in November of 2014, looked at patients treated with drug-eluting stents, and patients actually treated at the 12-month period. They were randomized to either continuation of aspirin and prasugrel or Plavix, depending on what they'd received, to aspirin alone. And it looked really at event rates between the 12 and the 30-month period of these patients, either, like I said, randomized to continued dual antiplatelet therapy or aspirin alone. And what that study showed was that there was a significant reduction in ischemic events, stent thrombosis, myocardial infarction, at the cost of increased bleeding on patients treated with continued dual antiplatelet therapy. Our study, as a sub-study of this, arose because in the pre-specified subgroup analysis of the original DAPT trial, there was a question, or there was observed a treatment interaction in the gender subgroup, meaning that on the outcome of myocardial infarction, meaning that it appeared that females seemed to benefit less from being treated with prolonged dual antiplatelet therapy as far as the outcome of myocardial infarction went. And so our study really took a look at that interaction in greater detail by pooling not only the drug-eluting stent patients that were presented in the original DAPT trial results, but also bare metal stent patients to sort of get a bigger cohort and more power, and looked at that treatment interaction, and also looked at overall outcomes in women as compared with females treated with prolonged dual antiplatelet therapy. What we did find was there was a treatment interaction that did persist. So women did appear to have a slightly decreased benefit with prolonged dual antiplatelet therapy as far as the outcome on myocardial infarction. But in general, prolonged dual antiplatelet therapy in females, just as it did in males, reduced ischemic events, stent thrombosis and myocardial infarction, at the expense of increased bleeding. So I think what we showed, just to take a little bit of a step back, there is definitely some literature in the field that suggests that women are different than men as far as PCI, as far as bleeding complications and outcomes. And I think that this is the first study, first of all, to really focus on outcomes beyond the 12-month period. So it's a novel study in terms of its outcome, and it's sort of the time period it's evaluating. And what we showed was that females, prolonged dual antiplatelet therapy will benefit females as it does males. It's an integer score, and you can get the online tool, calculator. And what it does is it really assigns the individualized patient a number, and that itself will categorize their risk going forward as far as bleeding versus ischemic events. So just because that probably sounds a bit confusing, but essentially what I'm trying to say is that this score is able to take the individualized patient, and based on their risk, their age, their presentation with either ACS or not, or prior MI, a bunch of different factors. It will essentially score them, if you will, and that score we've shown both in it was developed with the DAPT trial patient population, but it was validated also externally with the PROTECT trial. But that score shows us that there's a way to predict who is more likely to benefit and who is more likely to derive harm from this prolonged dual antiplatelet therapy. So I think it's helpful because I think it gets us to, we're really kind of in this paradigm, or at least it's more popular to think about personalized medicine, and that's where we're really heading in the industry. And so this is one of the ways where we can really treat the patient and not the stent. And so we're looking at patient characteristics and predicting risk or benefit. So to circle back to our study, this score, we were able to show in our particular sub-study that this score works in both females and males. And indeed, if you look at the DAPT score and apply it to females, it will predict which females benefit and which females tend to derive greater benefit versus harm from prolonged dual antiplatelet therapy. It seems like the tipping point, there's always a crossover, so it's not like 2 is the perfect number, but it seems like when we validate this both in the DAPT trial and the PROTECT trial, it seems like 2 is really, and I should I think I misspoke. We haven't looked at the female-male difference in the PROTECT trial, but certainly in what I've done with the DAPT trial, it seems like 2 is the tipping point. And there's a figure that is in our abstract that really shows that at 2, the ischemic benefit, so if we look at patients with a high DAPT score, so 2 or above, really they derive net ischemic benefit without really an increased bleeding risk, and the bleeding risk is actually 0 in females with a high, in this particular cohort, almost 0. So it does seem to be equally applicable to men and women. I think we see a little bit of a difference in the numerical value, in terms of how much ischemia we're seeing reduced, but again, the directional benefit is the same. Whether it's, male or females we're looking at, I think treating the patient and not the stent is a big one. And I think females can benefit just as much as males from prolonged dual antiplatelet therapy if we select the correct patients. And I think the DAPT score, obviously it's really new, but I think as people validate it more and more and use it, I think that that's the way to go really to start individualizing our treatment decisions.